Welcome to the Sports Pharmacy Network show, where we dispense clinical and evidence-based information to optimize health and human performance. I'm Brandon Welch, a clinical sports pharmacist and your host of the show. My guest today is Dr. Angela Garcia. Dr. Garcia serves as a consultant pharmacist for ambulatory surgical centers and is widely regarded as a leading authority in asthma management and respiratory conditions. She has contributed to sports medicine, grand rounds, and holds multiple certifications in spirometry, tobacco cessation, and functional medicine. Passionate about athlete education, Dr. Garcia focuses on teaching proper asthma management and inhaler techniques, helping athletes sustain optimal performance levels. In today's episode, we are tackling a highly prevalent respiratory condition in athletes called asthma. Asthma and exercise-induced asthma are highly prevalent among elite athletes than in the general population. When competing in the Olympic Games, fun fact, it's unusual for several athletes to rely on their asthma inhalers. In fact, asthma is the most prevalent chronic condition among Olympic athletes. A study covering 5 summer and winter Olympic Games between 2002 and 2010 revealed that around 8% of Olympians had asthma. More recently, a 2022 study of European athletes at the Summer Olympics found that 16.5% were affected by asthma. Research consistently indicates that asthma is particularly prevalent in endurance sports, such as swimming, rowing, cycling, as well as winter sports like cross country, skiing, and biathlon. It begs the question, why do some athletes develop asthma or exercise-induced asthma? While the exact cause remains unclear, today we will delve into the triggers of this condition, discuss the characteristics of asthma, and explore how this can be effectively managed by athletes. And all of this from a clinical perspective. And this is the first episode in a 2-part series on asthma management and athletes we will be covering over the next few weeks. In subsequent episodes, we will be discussing non-pharmacological and pharmacological options to best manage asthma and also explore the anti-doping policy around beta-2 agonists, which are common agents used to treat asthma or exercise-induced asthma. Now, to kick things off and to start our discussion, here's my guest, Dr. Garcia. What's going on, Dr. G?
How are you? I'm good.
I'm doing great.
Awesome.
Welcome to the show.
I'm excited to be here.
Of course. So, to kick things off with telling our listeners a little bit about your work and what has really made you a leader in this space.
So one of the things for me is I actually have asthma. I was born with asthma, had it. My parents, who are master's level educated people, fall into the category that most people do as being health illiterate. And so they didn't manage the asthma in a way that allowed me to be fully functional with my breathing. And it wasn't until I actually went to pharmacy school and started learning a little bit more about the physiology of my lungs, the physiology of the disease, and the types of drugs and why we want to use them. So then working with my doctors, getting my own asthma under control, it was a game changer. It totally changes what you can do. And had there been better management, I probably would have been able to be more competitive in sports. I mean, I'm not saying that this is why I am not an athlete. Happen to be a little bit shorter. The gait and the span of a step makes a big difference, especially in track. But most of the sports that I was able to tolerate were those short burst type activities, and understanding why. And so that was really something I was super passionate about, because if my parents, who were educated, didn't give me the best opportunity to prevent some of the lung damage that I do have now as an adult, there's got to be an opportunity to start doing these interventions earlier, get the education out. So very early on got involved with the South Florida Asthma Coalition, and then transitioned over to the Florida Asthma Coalition, which is the state level organization that's filtered through the Bureau of Chronic Disease, and then again with the partnering with the Department of Health. So that's an opportunity for us to really start building these asthma-friendly communities and centers of excellence And in the different populations that we serve, athletes are a missing component, because when we think about special populations with asthma, we think about seniors, we think about pregnant women, we think about kids. But athletes are a unique component um, of the disease management. And it's definitely something that there needs to be a significant conversation about, because we know how prevalent it is in competitive athletes, in elite athletes, and the fact that there's a better quality of life and safer way for people to be engaged in sports. Back when I was younger, if you had asthma, you sat on the sidelines. You weren't allowed to participate in PE. You couldn't do those things. And so when you think about the stigmatism of the disease and the I can't, or you can't, or it's not safe, you miss out on those things. And athletics is an important part of socialization and social development. And so those are a lot of things that really drove me. I've had the opportunity to work in clinics with some phenomenal providers, pulmonologists, primary care, who really have a focus on treating asthma. And it was just, the best environment to be able to grow and connect and partner with, this group of athletes. From a sports perspective, working in the Nova Southeastern University, Karan C. Patel College of Osteopathic Medicine, I was able to participate in the sports medicine grand rounds and talk about medications regardless of the disease. But it really came to the patients with asthma, the patient athletes with asthma. There's a lot going on because of how unique the disease is and how it presents differently. And so getting to a place where you want to educate the athletes just like a regular patient, and you want to educate the team that's treating the athletes, it's really something that I'm passionate about, and I love the fact that I have an opportunity to help contribute to that. So thanks.
Yeah, no, amazing story. And I always say personal experiences are the best way to kind of feed into, your areas of expertise and being passionate about educating, other people who can be dealing with something very similar. And you highlighted something which really kind of spoke to me or stood out is, these athletes, they're often overlooked is because I can see how it can be masqueraded or poorly assumed based off of an athlete. They're physical specimens. They're always training at high levels, and so we can easily think that when they're having shortness of breath or chest tightness, we can quickly assume that it could be like a thing of them over conditioning, or it can be a thing of them not being well conditioned, right? By having some of those symptoms of shortness of breath, when really it could be something like an exercise induced bronchoconstriction trigger or something to that nature. And, it's like you mentioned earlier, the treatment and the education is the same as if you were going to, educate or treat someone of the normal population.
And the athletes are a special population. Even the guidelines address athletes differently. It's a very small excerpt. Most people don't go to the guidelines to look for special populations and then athletes. But the American Thoracic Society actually has a component that's specifically dedicated to athletes with asthma, because these are things that they might present a little bit differently. And something that we've talked about before is the heterogeneity of the disease. And so the heterogeneity means it doesn't look the same for everyone. And the best way to kind of grasp that is when you go into an ice cream shop and you see all these different flavors, right? That's what asthma is when you come into a doctor's office. It could be any one of 15, 16, 20, 30 different presentations, because phenotypes are different. And you can have different phenotypes within a family, or you can have similar phenotypes, which is great because then everybody's responding to the same medication, and you're not moving around between different types of medications for different kids and confusing all of that. But your athletes really need to understand how to use their medications, which we'll kind of talk a little bit more in the part 2 series. But we have to know what the presentation of asthma for each of our athletes, because every athlete is unique. Their sport is unique to them. Their body's response to the sport and their body's response to conditioning for the sport and their body's response to the medications all have to kind of come together. And so having that group that can really think through these different components gives you the greater opportunity to make sure that you've got the right treatment comprehensively for your athlete based on whatever their presentation of asthma happens to be.
Interesting. Asthma seems like it's one of those health conditions that can be very complex, considering, as you mentioned, the different phenotypes and different clinical presentations that that can present for a particular patient. One of the things that I get asked about quite often, which I think you can explain very thoroughly, is what's the difference between asthma and exercise-induced asthma or exercise-induced bronchoconstriction?
So, asthma is an inflammatory based disease, right? And so we have different types of lung diseases. Some are obstructive, which means you get air in, but something obstructs the air coming out, and that's asthma or COPD. You have your restrictive airway diseases, commonly like a pneumonia or a cancer. Something is in the lung, so you can't move air in. And so that's very different. You treat those differently. You've got different levels with asthma, either the intermittent, so kind of ebbs and flows, different times, or your more persistent asthmas, which there's mild, moderate, and severe persistent asthma. And that's something that's around constantly, but can be managed. And when you have the right management, you don't function like you have asthma. You don't look like you have asthma. You don't feel like you have asthma. And the problem is we don't necessarily get them matched up the right way. We don't get them diagnosed at the beginning with the right stage of asthma, and then we're not optimizing the control of symptoms through different kinds of medications. With exercise-induced bronchospasms, this is something that both people who do have asthma and don't have asthma can actually have exercise-induced bronchospasm. So just because you have EIB doesn't mean that you have asthma. But about anywhere, depending on the study that you pick, 40 to 90% of athlete patients with asthma will also have exercise-induced bronchospasm. About anywhere from 20 to 30% of the regular population who does not have asthma, that group will present with exercise-induced bronchospasms. So it's not just something that athletic trainers and sports med physicians have to worry about only if the patient has asthma. And that's why it's really important to recognize those. So the asthma needs to be managed with controller medications, where your exercise-induced bronchospasm, you can do some prevention. There's things you can do, which we'll talk on the non-pharmacologic side, to help improve the breath cycle, those sorts of things. But really kind of looking at how it's presenting, what are some things that can be done, what are some innovative ways to look at, checking your patients to see if it is exercise-induced bronchospasm, or your athletes from a performance perspective, not just reporting clinical symptoms. And so that's what's really kind of unique about making sure that your athlete either has asthma and exercise-induced bronchospasm, or they have asthma but they're not exercise-induced bronchospasm tendons, or if they don't have asthma but they still do have an exercise-induced bronchospasm.
It sounds like asthma is more chronic and exercise-induced bronchospasms could be more acute.
Right. So the exercise-induced bronchospasm, you'll see that beginning within 5 to 10 minutes of initiating a pretty substantial exercise. So warm up, right? You kind of want to, you start off a little bit and you increase the intensity over time. Once you start to increase that tendency or intensity, and then your athlete engages in an endurance level sport or an intensive sport, you might see that begin there in that first kind of 10 minutes. Plus, when the exercise activity or the performance activity is finished, you kind of have this other window, 15 to 20 or 30 minutes, where you might see kind of a flare up after the fact. And with that acute onset, the best thing that we can do is recognize early what kind of symptoms your athlete is having to try to prevent those. And then if they show up, what you can do with your athlete, depending on where their level of competition is, what restrictions they might be under, how to treat it so that they don't have to remove themselves from their event or activity.
So, assuming one is undiagnosed and you have an
Mhm.
athlete, on the field, what are some common symptoms of asthma or exercise induced bronchospasms that athletes can reveal to coaches, or that coaches need to be paying attention to best take care and manage these athletes that may present with some of these clinical presentations?
So what's great to differentiate, right, is that you're looking for the outlier symptom that's not common between other things. Just a hard exercise or a hard, training in the heat, inside of a facility that might be a little bit colder, you're going to see the same symptoms between somebody who's got exercise induced and who doesn't. The outlier piece is really that thing to watch for. So the things that are similar between the two, the exercise induced bronchospasm and those that are not, maybe it's a conditioning, maybe it's, something is, you're going to get that feeling of chest tightness, right? So you've done triathlon, so when you're kind of in the midst of that endurance activity, you're really forcing yourself to take these deep breaths,
Hmm.
right? When a person that has the exercise induced bronchospasm, they are going to do the same thing as a person who doesn't. You're going to take those big breaths, you're going to try to get that oxygenation, and you're going to get all of that metabolic, your body needs the oxygen for the cellular at the metabolic level. And so you're trying to take those deep breaths, right?
Hmm.
That chest tightness and that shortness of breath, that's a sensation that they're both going to feel. One of the bigger differences is the presence of wheezing and cough, right? So you'll have fatigue, you'll have a hard time, sometimes a hard time talking in a normal sentence, right? You can kind of think about athletes that have just run or spent 15, 20 minutes training, bike, warm up, whatever. Their speech pattern is a little bit different, right?
Mm.
The recovery from that, right, very quickly lets you know that there's probably not something going on with the airway. When you have the exercise induced bronchospasm, you have a very quick narrowing of the airway. And that's kind of triggers and starts in some of that broncho constriction and bronchospastic. You get the hyperactive airway. You might have some other components, especially if there's an underlying asthma. But that wheezing and the coughing are some pretty significant signs that there's something going on here that's different than just an intense workout and feeling it, after the fact. Especially if your athletes in a different season and they're not doing multiple seasons of competition, right? So they're reconditioning in, right? You got to differentiate building back up stamina, some of those things. Things that are important to find out about your athlete is, have they recently had a chest cold?
Mm.
Because that may or may not be a contributing factor. Do they have underlying allergies? That may or may not contribute to it. But knowing there's a couple of things that we really watch for. A lot of times, people with asthma will scratch at their throat,
Mm.
right? Because as you're having this reactive airway, there's a sensation, and so you kind of see some of that stuff. So you see some physical things that your athlete's doing. You notice the wheeze, you notice the coughing. If they're coughing, it's usually exercise induced bronchospasm. If there's not a cough there, you have to look at other things that are going on. And you can test, right? So you can do spirometry, and there's
Hmm.
desktop spirometry. You can get certified in that. And within 30 minutes of your activity with your athlete, you can test and you can see what's going on. And it's sort of like when you do HbA1c with your diabetics. You can tell kind of if they've been adherent, what's kind of going on in the big picture, longitudinally. You can look at the same kind of function with your athletes. So they're not going off to the pulmonologist to get the lung function testing. And this isn't diagnostic in any way, but it gives you a picture of what's going on. And you can see some of that bronchoconstriction. And that gives you a sign then, beyond just the clinical symptoms of cough, wheeze, scratching, some of those other pieces, that can be a little bit more, give you more confirmation. And there's pheno testing. So the forced expelled nitric oxide. So
Hmm.
pheno, You can do, again, desktop handheld devices that can test that and show if there's a level of inflammation going on. And so, kind of looking at that is really how you can start looking at some of those things to differentiate what's going on and if it's really something that's more prevalent for exercise-induced bronchospasm diagnosis.
Now, considering, if exercise-induced bronchospasms, if it's acute and if one doesn't have asthma, is this something that can be overcame? Is it something that could be due to, I know you discussed it possibly being a trigger from allergens or irritants. Assuming that this is something that that an athlete can potentially get over, is that an accurate assessment?
So the bronchoconstriction will stop. But in the midst of that bronchoconstriction, it is a very scary place to be because if you can't breathe, nothing else matters. Your brain, your body needs oxygen and it's going to do what it needs to do. You might start getting numb in the fingers, numb in the toes. Sometimes, you get kind of dizzy and those sorts of things. And so it's a very scary component. And then people start to hyperventilate because they're panicking about not being able to breathe. So that's where, and we can go a little bit more into the non-pharmacologic things to do, but breath work and breathing technique, learning deeper breaths and controlled breathing is a huge piece to help athletes with asthma and help athletes with exercise-induced bronchospasm to make sure that their breath cycles are very controlled. As they are increasing the intensity of their exercise, they have to be more and more mindful of that to help sort of stave off some of those things. They can use medications, but if they're not using a spacer, I can say confidently 85 to 90% of the time, people are not using them the right way. And you need to
Agreed.
use a spacer because all inhaled medications are topical. So you think about it, if you get a mosquito bite, you're itching, you put it on, if you got a bite on your arm, you put cream on your leg, it's not going to make this stop. It's the same thing for inhaled medications. If it doesn't get into the receptor in the lung where it needs to act, it's not going to help relieve that constriction or inflammation, depending on which medication you're inhaling. So with the rescue medications, which help those bronchodilators, right, will help to dilate the bronchi and calm down some of that spastic or hyperreactive component. You have to use them. You have to use them the right way, and the spacer is the best way to ensure that it's getting where it needs to go. And you have to use it in enough time for it to have an effect before you start increasing that intensity. So you should, for an athlete who either has or might be suspected to have exercise-induced bronchospasm, you want to make sure that they're pre-medicating with their rescue inhaler or their short-acting beta agonist. You want to make sure that that component is there 15 to 20 minutes, 30 minutes before their activity. And that's going to stave off things for several hours. If you find out that your patient athlete with exercise-induced bronchospasm pre-medicates, does okay, but starts to have symptoms before the end of their activity, like maybe it's soccer, maybe long distance running, those are probably indicators that it's not just exercise-induced bronchospasm, but there might be an asthma component related to that. That's either undiagnosed or not necessarily being treated. If your patient athlete has asthma, you treat the asthma successfully, you can reduce some of that exercise-induced bronchospasm because you're suppressing the inflammation beforehand as a component of their day-to-day. So, those are things to kind of be aware of and think about because it's a benefit to your patient athlete to know how to use their meds, when to use their meds, to progressively increase that intensity so that they're kind of primed then, because the lungs need to be able to function differently. And, a lot of it has to do with your breath, right? So when we normally breathe, we breathe through our nose, right? Mouth breathing is not a good thing for our lungs and our heart. It doesn't, like, we need our nose to filter out pollutants and allergens. We need our nose to warm the air that goes into the lung. when you're competing and you begin mouth breathing, right, you are going to dry out and dehydrate the cells in the bronchi,
Mm,
which is a quick trigger for that bronchospasm to happen. We think about hot and cold, and really it's the dryness of the air. Like if it's too humid, it can be a little hard for a person with asthma or can become a trigger for bronchospasm. If it's too dry, it can. So even
mm,
if it's hot and dry versus just cold air and dry, usually cooler air has less humidity. So it's more about if it's too dry, it's sort of like Goldilocks and the Three Bears. Can't be too far one way, can't be too far the other. You got to
mm.
be just right, in that
Yep.
sweet. And so just kind of having that awareness of what the environment looks like. If you're outside, how hot is it? Is it safe for those athletes? Do they need to pre-medicate and have their medication with them out there, not in their bag or their locker inside? Thinking about the environment, if you're where your athletes are practicing, if there's highways, if there's a train track, right? Those things kick up particulates. And so they're called aeroallergens. They're things that are in the air that we breathe in, and we don't have to see them for them to be there and affect us. New tar, using shredded tire on a track. When that heats up, there are VOCs that are released from rubber and other synthetic products that can become triggers for your athletes. What cleaning products are used, right? There's a residue chemical that's left over that can trigger your athlete whenever they come in the gym to exercise or train.
Hmm.
Um, so there's those things. People that wear cologne, people that have perfumes on, plugins into the wall, anything that's in the air is technically a potential trigger, because
Mm.
the only thing that should be in our lungs is oxygen, and anything that else that's added to the air that's breathed in, some people are more sensitive to that. So you kind of think about those things and how to prevent as many triggers from the environment. Um, and then, whether there is or isn't an underlying disease state that might also need to be balanced.
I would say too, with athletes, especially collegiate and professional athletes, traveling to play
Yep.
in different geographical areas. I
Mm-hmm.
mean, it's very important that they keep their rescue inhaler, or if they have asthma, maintenance inhaler on them. And I would even
Mm-hmm.
say athletic trainers, I'm sure that they have an emergency treatment plan where they carry, maybe a rescue inhaler as
Mm-hmm.
part of their travel, medicine bag that they bring when they go to different, geographical locations in the event that someone is very hyper responsive, to your point, and has any of these exercise induced bronchospasm events.
Right.
And
And
so,
when you
yep.
think about when the athlete's in the midst of that, right, to take a nice controlled deep breath, that's not a thing.
Mm,
Like you can't breathe. You're not, no matter who's coaching you through the breath, you're not thinking about that. You're trying to get oxygen in. The problem is if you have underlying asthma, you got air in, you can't get it out. So you keep breathing in thinking that's the problem, when really the issue is about breathing out. So changing the breath, getting that oxygen out of the lungs, so then you can actually get good oxygenated air into the lungs. Having a rescue inhaler and a spacer is really essential for travel with when you have athletes. You have to think about altitude. That is also another component for your athletes, because
yep.
as altitude goes up, the dryness of the air goes up. So even if it's not cold, or you're not registering it as winter and cold, there's a potential trigger there for your athlete.
I know too. One of the things that I asked you about prior to this podcast was with swimmers, right?
Mm-hmm.
Swimmers, when we're thinking of potential triggers, the chloramines or the chlorine inside of some of the waters that they may be practicing or swimming in,
Right.
those can be potential triggers as well.
Mm-hmm.
For exercise-induced bronchospasm. So,
Right.
say least, making sure that we're well equipped and well prepared in the event we have any of these potential triggers, I think is going to be key. Because,
Yes.
at the end of the day, it's all about health and safety when it comes to these athletes.
Right. Exactly.
So, how can healthcare providers differentiate between an athlete's poor performance due to exercise-induced, bronchospasm versus other factors like fatigue or fitness levels?
With exercise induced bronchospasm, they're more likely to occur within that, first 5 to 10 minutes of intense exercise, and it will last probably for anywhere from 10 to 15 to maybe 20 or 30 minutes, right? So you've got a span. It kind of depends on your athlete. But a person who's maybe not conditioned well, they're going to
Hmm.
recover as soon as the activity's over, right? So that exercise-induced bronchospasm, and specifically that coughing component and potentially the wheeze, that's going to last after the exercise stops. When you don't have the bronchoconstrictive or hyperreactive component, um, as soon as it stops, all your symptoms are done,
Mm.
right? And that's, like when you're running, right? As soon as you're done, your hands are on your hips or your hands are over your head. You're trying to open up that airway, right? Your lungs to get air in. You're good, and within a couple minutes, you're fine. The athletes that have the exercise induced bronchospasm, they can still potentially be symptomatic
Hmm.
for a little while after they are done competing. So noticing that, when you're in short endurance sports, right? So things like soccer, volleyball, sprints, right? Field, doing track and field, so field events, those things, you have those bursts of activity, things that are maybe, up to 8 to 10 minutes in length. If the intensity goes over that, that becomes more of a trigger for your patients that have, or your athlete patients that have exercise induced bronchospasm with or without asthma. So in that first 5 to 10 minutes, if you start seeing some of those things besides chest tightness, right? That cough, that wheeze, definitely struggling to catch their breath, that's probably a pretty good indicator that there's something going on. And at that point, they need to be tested. There's a lot of literature that says, you don't need to test every athlete, but, certainly the ones that have histories, when you're doing, it's just like when you think about seeing a patient, right? You take a family history, you get a really good history and physical.
Yep.
Um, so if somebody has had asthma ever, you should have a baseline pulmonary function test on them. If they have significant allergies, if they have eczema, because the triad that happens is allergies, eczema, and asthma. And so any of those kind of components would be a definite, we got to get a baseline lung function test done and see what do we have going on here? What kind of inflammatory processes do we have, constriction or restriction happening? Because then you can start to look at those athletes, and then using pheno or desktop spirometry testing to see what their actual physiologic response is after their athletic performance.
Hmm.
You can start to see those changes, and you'll see some of these, because some people with exercise induced bronchospasm, they don't necessarily have these symptoms that are those classic or hallmark type symptoms. They just know that they're having a hard time breathing, and so it's really hard to describe what you're feeling when you don't have an outward symptom. So
Yep.
for trainers, for coaches, really watching the breath, watching their respirations, how frequent they are they able to recover their breath? Are they, showing some of those other, signs where they're constantly coughing after they run? If there's wheezing, those are those major pieces to really watch for in your athlete.
Yeah, because athletes, they can, go through a long period of time thinking the shortness of breath and sometimes the chest pain is just normal feelings as part of the conditioning hard, when really it can be a little bit something more serious that needs to be, more heavily looked at.
Right.
And
And
so
it
I,
could be just cardiovascular, not just, you're thinking about the bronchospastic piece. One of
right.
those big things for athletes to understand is, as soon as we're done, start thinking about your breath. What's happening with it? Do you still feel constricted? Are you coughing? Is there wheeze? Is there anything that's itching and feels like kind of a histamine release? Because those are things that, like, the mast cells get activated. They release the histamine, and then you start to feel the itching. But those are really kind of things that they have to have an awareness. And so it can't just fall on the trainer and the coach. Your athlete has to know what some of those symptoms are. They have to understand this is something that you may have lived with and have normalized, but it's not normal. And you don't ever want, from the psychology side of sports, you don't want somebody thinking that they're underperforming and pushing themselves to a place where they're not safe
Right.
because they can't do something or they feel like they can't, when it's really something that can be managed, pre-treated, or treated, daily if they do have asthma, that allows them to overcome that hurdle. And then their performance is great, right?
I mean, look
Throwing,
at Noah Lyles. Noah Lyles, top,
right? Yeah,
Olympic sprinter. I mean,
yeah,
he suffered from asthma and he does just fine.
great.
But to your point, I mean, it's important to make sure you have your own self awareness and be upfront and honest when
And
things
thinking
don't
about
feel right or normal.
Right, right. And thinking about other things that kind of come with those inflammatory based diseases, migraines, having, again, the eczema, allergies. Sometimes, ADHD is another component that they're really kind of looking at. How do all of these kind of line up? There's a similarity between these disease states, and there's different inflammatory markers that are present, and maybe they're not linked, maybe they are. Studies need to be done to really kind of do some confirmation there. But the more the things you see in a patient that may have a inflammatory component, the more likely there is some thing there that needs to be watched. And the biggest thing is, once an athlete or a patient has been exposed to a beta 2 agonist,
Mm-hmm.
and steroids, you're either going to breathe better or you're not. Because if your inflammation is there, the steroid is going to take care of that. If the hyperreactivity is there, the dilator is going to help to take care of that. And it's not something where you want every athlete trying it and exposing, and but there
Right.
are characteristics and there's histories for your patient athlete that are going to be clues that we need to check this out, and never hesitating, to get a pulmonologist and an allergist involved to do those tests, to say, can we rule it out, right? Because you could have vocal cord dysfunction, you could
Mm.
have cough variant asthma, you could have GERD, right? That presents, and as they have that reflux, there's wheezing, the vagal nerve stimulation, like all of these different things can be a component of hyperreactive airway, bronchoconstriction. You take care of some of those things, then you're not talking about the asthma or the exercise-induced bronchospasm without asthma. So the differential becomes an important component.
It's like the best thing, we tell our athletes is to make sure you listen to your body and be
Yeah,
honest with it. And when something
absolutely.
doesn't feel right, let somebody know.
Mm-hmm.
It's only to protect, again, your own health and safety for the long term. No need to push through it if you don't have to.
And an athlete, understanding conditioning is supposed to create and strengthen the lungs, right? And
Right.
especially if your patient has asthma or they have asthma plus exercise induced bronchospasm, the more they are primed in for their endurance, right? There's a thing called the asthma advantage,
Yep.
right? And you've probably read about that.
Yep.
It has come out in the Olympics, right? Because they're
Yeah.
like, all these patients, all these athletes are getting gold medals,
Yep. It was
and
like 16 Olympians I was reading. I was like, my God.
lo and behold, they are all asthmatics, and lo and behold, they're all on meds. And before we realized that, they did test, and they're like, no, this isn't why they got gold.
Yeah.
What you have to do to compete at an elite level gives you a different level of lung endurance,
Right.
hence performance. So asthma doesn't have to be something that's a scary or game calling, disease state. If you train correctly, if you treat it correctly, it actually gives you a protective factor in your lungs, and the training that you have to do to manage your asthma and compete with asthma gives you some interesting lung competitiveness that some of your other, teammates or your opposition doesn't necessarily have. So, it's kind of, there's a sweet spot in there, but it really comes from the athlete knowing their body, the athlete knowing the disease, the athlete knowing the meds, and having that relationship and conversation with your entire care team. And athletes should be encouraged to say, I can't breathe when I'm doing this. Look at how the timing is. Is it kicking in at the beginning of exercising or training? Is it lingering afterwards? Well, then there's reason to find out if and do some additional testing.
Mm.
And where if it's just a performance issue and not an underlying bronchospasm or asthma issue, then recovery is quicker, right? So there's two things in conversation with your athlete to start helping you figure out which kind of road you're going down, and then what changes or things to do to improve their performance.
I couldn't agree anymore. You touched on some really good points there. Now, where can athletes and coaches find reliable resources or professionals to learn more about managing exercise-induced bronchospasms or asthma in general? You know that we're inundated with so much
Right.
information out there, but where is a good, reliable, and reputable source for people to go to?
From the functional side of it, right? Having a good relationship with a pulmonologist and an allergist is good, right? Somebody you can call on. There's local unit associations. So you have your pediatric pulmonologists in several different areas, especially within the state of Florida. We're so big, we usually have some regional groups. The European Academy of Allergy and Clinical Immunology actually has a work group. It's allergy, asthma, and sports, and so they do some publishing. They have some kind of best practice. They'll do some kind of notes and things out in circulation, and that's a group that's really specifically looking at how allergy and asthma affects sports and sports performance and athletes. And so that's a great group. You also have, it's called Quad AI. So it's the American Academy of Allergy, Asthma, and Immunology. They do a lot of publications. There's a lot of conferences there to kind of look at, what we're doing with meds and treatment and prevention. And so you'll see, again, some of your athletic trainers, some of your sports med docs will be in those groups. You have the American College of Allergy, Asthma, and Immunology, so we call them college. That's another group that's very specific to asthma and immunology and the inflammatory pathways. And so they all have times and where they published or put out statements. They contribute to the guidelines, but looking for some of that, the American Thoracic Society, ATS. You've got the NAEPP, so the National Asthma Education Prevention. You've got your GINA guidelines, which are your global. So you've got places you can go to get that information. But relationships are really what you can't miss, right? And shameless plug for having your pharmacist around who can really kind of talk about meds, technique, make sure that your athletes are repeatedly being re-shown the technique for inhalers. There's a lot of studies out there that show people think they're using their inhalers right. They're not.
Which is why they need the spacer.
Right. The spacer definitely improves it, and there's differences in the medications, and some people think you can, and some you can use with spacers, some you can't. Dry powders you can't.
Yep.
But so knowing the medications and knowing which ways to give your athlete the best, because if your athlete's bronchoconstriction is suppressed or well controlled, if their asthma is well controlled, then there's no difference in them being able to compete or perform at the highest levels. They can be elite athletes, which we see, in the realm of the Olympics.
And for our listeners, we will add all of these valuable resources in our show notes, so no need to remember them from from listening to our podcast here. But Dr. G, you unpacked a lot of rich information in this podcast show. I'd be remiss not to mention, where is a good place for our listeners to find more about your work and all the great things you're doing out there to support athlete health?
I just, as a consultant, just working and word of mouth, but I can, add my email to your podcast notes, and anybody can reach out to me, say, hey, I've got some questions. I love to collaborate and partner with sports med docs, athletic trainers, coaches, even the athletes, or families of the athletes. But that's, certainly something that I enjoy being able to do, is be a part of the solution to making the quality of life and safety as high as it can be for the athlete.
And you're pretty active on LinkedIn, so look her up on LinkedIn, Angela Garcia. You'll find her on there if you have any questions too. Anyways, that concludes our podcast show. That's all we have time for today. Thank you guys for tuning into this week's episode. We hope that you found the content of this episode insightful and thought-provoking for both your health and performance. If you do, remember we are going to build on this topic, talking about non-pharmacological and pharmacological ways to best manage exercise-induced asthma. So stay tuned for part 2. Back again with Dr. Garcia. As a quick reminder, guys, you can sign up for our newsletter or exclusive membership offering through our website, sportsrxnetwork.com. Follow and share our content on social media and subscribe to our podcast. We will include any relevant studies or references in the show notes. And as a reminder, the information provided by the Sports Pharmacy Network is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Thank you again for listening to the Sports Pharmacy Network podcast. We look forward to you joining us on the next episode that drops in 2 weeks.